being told that the funds aren't being released to get paid until after the patient has been released from the hospital. So I totally agree, and I'd like to see some guidelines, or ask you for some guidelines to be put out to all SSAs and county boards, because we're definitely hearing that families are not getting that authorization. And you know, some of our kids are very complex and could be in for weeks and months, and that's just not going to work. So we'd appreciate your help in clarifying that. My direct question for you today, though, is to further advance the issue of independent provider certification. This affects families who have children and adults with very complex medical needs, mine included, as well as many families that I support who need nursing. And independent providers are very valuable to our kids. Mine is an adult, so he cannot get up out of bed on his own. And we support many families like mine. Nurses aren't available in all 88 counties. In rural counties, families do not have an agency to go to find a nurse. They don't have an agency to go to find an appropriate provider for our complex care individuals. And we have to have an independent provider option. We have to have an improvement on the certification process. Now, I hear loud and clear, P&M, EPD are very complicated, they're a mess, they're not good for your staff. All staff that's here today, you know, is really struggling with these changes, and I get that. But our independent providers are so critical to our loved ones' lives in Ohio. We don't want to be treated as the stepchild anymore. And we really need your help. We need help to get the certification process timeline significantly decreased. We can't wait for months on end to get my son out of bed when my arm hurts and I'm going to physical therapy. And many families here today are just like me. We're older, we need help. And so I want to ask you again, can DODD work on that? Are you all ready? What has happened since April when we talked about it last? And I thank you very much.
Thank you, Amy, and I think we agree on both the importance of independent providers to our service system and to families, individuals served, and I know, I hope you know, that improving our provider certification process is really important to our director and to DODD right now. I'll say that one good consequence of the increased rates that came with the latest budget is a real increase in provider applications. So we have seen a substantial increase in provider applications. And so we're thinking about and looking through our options for 3 different ways we could improve the process right now. One is, do we need to make some adjustments to workflow to review applications for completion earlier. We are looking at whether we can put into place system changes to allow for independent providers who have individuals waiting to be served to be kind of moved to the front of the line. And we're longer term looking at whether we need a budget ask for some additional staff if the number of applications we are processing each month continues to stay at the elevated level they've been at for the last 6 months or so. So all of those are potential options for us to move forward with. So not necessarily through an agency, we do have some options for that, that, we can think about as well, if it doesn't mean necessarily waiting until the next budget as well.
Can I just make a quick, hi, I'm over here. Just a quick comment on the hospitalization reimbursement. I'm a support administrator, and what I'm finding is that it's not very clearly defined on how if families could be reimbursed, or if caregivers could be reimbursed. What I've heard from 3 different supervisors in my county is that's a nursing task, so therefore that person cannot be compensated. And then the adjuster says, oh yeah, they can. So I think there needs to be a lot of clarification as to what tasks are specific to the nursing in the hospital versus the caregiver that's at the bedside.
Okay, we can continue to try and provide some more guidance on that to counties as well. Thank you.
Thank you for addressing us today. I would like to go back to, you said that the NMT was going to change, and just could you clarify the changes there?
So we're creating a new rate for individuals who are using NMT to go to competitive integrated employment. So if you're transporting individuals to using NMT to anything else, process will stay the same. If you are transporting individuals using NMT to competitive integrated employment, we'll have new rates available, hopefully with an approved January. This is all required CMS approval, but with a approved waiver amendment for January 1.
Hello. Down here.
Got it. The hands help.
Yeah, I really didn't need this thing. I guess my concern is when it comes to the dodd applications, we are allowing agencies 60 days to get a background and get everything done, but they're allowed to send people out to care. So I don't quite understand why in the dodd system within P&M, why can't there be a box added that has consumer waiting so that those people can automatically start providing services while they're waiting on this process to go on, because it's a little bit of craziness and madness at the same time.
So we can't, we can add a box, we could add a box for consumer waiting to be served to hopefully maybe move up the application process and improve process. So we can't allow independent providers to provide services without the application being approved, but we are, particularly since we've passed July system changes we've been working so hard on, looking at whether that system change could be helpful to help expedite the process for independent providers who have individuals waiting to be served.
Okay, so when I applied and started a dodd agency, I'm just going to tell all these people, just come on over here. We'll pay you the 80% of the agency rate while you're waiting to get your IP, so that these people aren't doing without services, because too many people are without services waiting on this. And we're supposed to be about health and safety first.
I understand that. I'll say that the agency has some responsibilities as an agency provider to ensure the health and safety there, which is why there's some differences in the application and certification process. But we do hear the concerns about the independent provider certification wait time and are looking at multiple ways to address those.
Thank you.
I'm sorry, you already answered this question. Once DOD approval, then you have to wait for Medicaid. Do you know the average wait time for Medicaid to approve after you get your certification from your contract agreements? For independent?
It's close to 30 days right now.
30 days. And I have one more question. For the NMT change, is providing services with wheelchairs, is that being considered as well?
An additional rate for if you were providing services to
Yes.
in the wheelchair. Right now, there's not.
Hello, my son is on a waiver. I got a renewal of his Medicaid. sorry, I went to Northland, to the office there, dropped my information off. Then they said they wanted more information. So I went there 3 different times. The last time I was in 3 different lines for 3.5 hours for them to tell me they didn't work on long-term health care there. That next time I needed to go to Wilson Road. So I'd like people to know that. Don't go to Northland if you're trying to find an answer out for long-term care and turn your renewal in there, because it doesn't work. I was on hold with Medicaid for 2.5 hours. As this lady said, I just took a walk, I took a drive, and just kept my phone on hold. And I was wondering, as far as this SIS, are we going to get a look at that to see what that looks like ahead of time? To know what we're looking at, how our kids are going to be assessed?
Yes, I think, we'll certainly do a lot of education as we're moving that forward to make sure that, all of our stakeholders, families, individual served, providers, county boards, see the assessment before it's in use.
Okay, thank you. And also, as far as hospitalization, my son was in the hospital. It was just transparent. The providers got paid. But it was 60 days per year. Now it's been changed to 30. And some kids get sick a lot. And I can't leave my son in a hospital room by himself. So that was extremely helpful. So I hope at one point we change it back to 60, because a lot of kids have, health problems. And they can't push the button. My son's not verbal, so. And I've been trying to get an independent provider on for months. Just the process. She had a number previously. We just found out yesterday she had to be remapped. I'm like, what is remapped? So it's not very streamlined. It's not, and as far as, I know you guys don't have anything EBB, but it's something we have to work through, but it's not easy. And I noticed the EBB units aren't being sent to Medicaid because it's coming up as errors. When I pull up the EBB report, the times we've clocked in and clocked out, it's not there. And it's showing, it's erroring. So will we continue, is that some glitch that's going to be fixed down the road?
I don't know enough about that specific one.
Okay.
But certainly, if you're clocking in and it's not recording it is, then yes, I would expect that that's an error that needs to be addressed with SANDATA.
Because at one point, I know we have to do this, and I'm fine with complying. I'm fine with that. But is there a time frame where it's mandatory or you won't get paid?
So there will be a time frame for that. It's not set forth yet for any DoD waiver services. So again, it's starting that process with its state plan, home health services, and letting that process go forward before moving on to other waiver services. So it is not yet affecting payment for DoD waiver services.
Okay, thank you.
And as a reminder, Jesse Wyatt, who is the Director of Long-Term Care for Medicaid, will be here at 2:30. So if you don't know who he is, grab me and I'll point him out. You can talk to him about long-term care. Sure.
And I called him and told him, you better bring somebody from Sandow, because they're here to get you. And they might as well. It's silly not to.
Do we have anybody from Sandow?
Well,
Yeah,
I
they really
think,
did.
because I've been around a long time, as a lot of you know, it is in state law that Ohio uses SANDATA. So my suggestion is you talk to your legislators and get them to change state law. It is actually, and it wasn't this administration, it was a long time ago. And it's in state law that independent providers must use SANDATA and agencies don't have to. So talk to your legislators. Anything else?
Right here. Sorry about that. I'm going to throw you a bone, switch from EBB. 2 questions. When the onboarding and the support intensity scale rolls out, will there be different more discrete, deep, like funding bands? Or are we gonna still have the same funding bands? My second question, completely unrelated. The FTC in March of this year just came out with a ruling that banned certain non-compete clauses. A lot of our agency providers make their DSPs sign non-compete clauses. So as we're talking about the lack of our independent provider network, we have folks who are getting a taste of our field, want to do the work, but then are forced out because of economics. So hey, maybe I'd like to do this as a career, and being an IP is going to be my ticket to the working middle class. But this provider, now I have yet to see in civil court in Portage County that any provider said, hey, I'm going to take you to court. But for where our DSPs are, independent or agency employed, they're going to look at that, they're not going to have the fiscal resources, and they're going to leave our field. I believe September of this year, that FTC ruling goes into effect. And of course, I think we all understand supremacy laws of federal into state, but I also think if it's not explicitly in rule, that's going to be a real blind spot for our provider network, because we want folks who want to make this a career, help them to make it a career.
So, first on the CIS, we're still kind of working through how the CIS and acuity and funding ranges will work. I wouldn't expect everything to stay the same. I can't, explain fully what that's going to look like in the future and why lots of, I'm sure, conversations with families about that. Also, give agencies legal advice on how to comply with the new FTC rule, but I do think that, it's going to have an effect on a lot of industries, including ours. I think that's a helpful thing to keep in mind.
Hi, Alan, thanks for being here. I have two questions. One is, do you know if agencies, employees get their background checks returned electronically or via email?
I'm going to turn that one over to Janet.
It depends. So some agencies can buy a system where they would get them electronically, but what I can tell you is if there is a hit on a potential employee's background, that's always mailed, which sometimes you get them in 10 days and sometimes you get them in 50 days.
So could DOD have independent providers' background checks sent to them electronically instead of snail mail?
Don't know if they're, so you meaning an independent, someone wants to be an independent.
Correct.
They have their background check.
And it's snail mail?
I believe that is standard. So just from my experience as an agency provider, if there is a hit, that is mailed. If there is no hit, sometimes those go through quicker. I don't know that it's possible to get them electronically. I've just never seen anyone get them electronically.
But I thought you just said that some agencies do.
They do, and if there is no hit, an agency can see that, but they don't get the actual documentation from BCI. They get that in the mail. They can tell when they submit it if there's nothing on the background. What agencies can also see is something it's called mail to, which means you're going to get something. We don't know what it means, but you'll get something. So sometimes they can tell if there's a clean background check quickly.
But couldn't you just go ahead with the independent provider if they had a clean background check?
You still have to have the documentation on hand. That's true for an agency provider too.
But does the agency provider, is that what the 60 days is about? They can start their employees, but they have to have their background check back within 60 days?
Right.
Okay. My other question's for Alan.
Okay.
Alan, you're not
I'm
saying
happily
that.
turn it back over.
Okay. I'm gonna put you on the spot here a little bit.
Okay.
Okay, so we talked in November, and we're thinking about, expediting complex care applications and/or for families who are waiting for services to expedite those applications. And it seemed like it was a pretty simple decision when we talked. Then in the beginning of April, again, you're gonna look into it and you're thinking about it. And I've heard you say many times in the last hour, we're thinking about it, we're thinking about it. From what I comprehended or taken from our conversations and in groups, is that that particular decision, just, I don't understand why it's taking so long. I just have this thought that if you wanted to do it, you could do it. So I just need it to make sense why you're not doing it.
So I think if we're going to make the change, we want to make sure it's going to be worthwhile and make a significant difference in the process. And so there's been a couple of things kind of delaying that. And one of those is just the IT resources to make sure that we can have that system change done, because we were spending a lot of IT resources, all of them really, on the July 1 go live of the home system. And so we wanted to make sure that PSN was working with PNM and with the fiscal intermediary to make sure we were continuing to process applications and pay claims as necessary. So that was a delay for us. And the second was, we want to make sure that the rising application was going to continue. We saw that in the beginning of the year, which kind of slowed down our application processing time a little bit. It had been improving in a way that I was happy with, and the increased applications has, pushed that back up a little bit more. And so as we're seeing that continue, I think it makes it more likely that we're going to continue or consider those workflow changes to make sure that individuals who are waiting for care get their services. But if it was going to move the process up only 3 days, would we want to invest all that in IT work and things like that? I don't know if that's necessarily worth it, but with the increase in applications and with the IT resources becoming available again to us to make those sorts of changes, I think that makes it more likely.
And this is going to have to be the last question, because we've got to get on to the next, we're half hour.
Okay, we were given a date of October 1st as our EBV, and this might be not your question, it might be Jesse White's question. That our claims that match our EBV, they were going to be denied. Because there's so many piles of us send data and EBV and all this stuff that I don't actually deal with. Are you pushing that date out, or is it still October 1st?
That October 1st date is only for state plan home health services. It's not for DoD waiver services. There's not a date for DoD waiver services.
So we do have Medicaid waiver providers too.
Yes. So for Medicaid state plan home health services, as far as I know, that is still the date. But for the DoD waiver services or other Medicaid waiver services, there's not a date yet for those.
Thank you.
Thank you. Thank you all.
So we always meet with the department regularly about certification, specifically independent providers. One of the unintended consequences of the big raise is that I also am getting calls from parents who are concerned that people are trying to become providers because the rate is high, not because they will potentially be a good provider. We all do this for other reasons than just the buck, but $30 an hour is attracting people. So I'm going to need your help on committees on, so what are the qualifications? And we talked a little bit about that. Do we need? Because we know we have background checks that, even if it's a family member, we need that background check. But how do we do it? Yeah, go ahead, John.
Can we use ODM's requirement to be an IP? Because out of all the waivers, and I'm an IP at all three, dodd is the most laxy-daisy, and I'm like, what is up with
Right.
this?
She's asking, can we use ODM, the Department of Medicaid's
Yeah.
certification requirements? There has been a movement for years that there should be the same requirements for aging, Medicaid, and DODD. Maybe it's time that the families are the ones to say, hey, and this is what we want. So we've been invited to, the ARC's been invited to sit at the table and discuss certification again. So we'll be calling a meeting, even if it's Zoom, to get your input on what you need. And it's going to be things like, I don't want to take Stephen's time, but can a provider be 16 years of age? Do they need a high school diploma? If I have a do not resuscitate order, should my provider be mandated to do CPR or first aid? You know, those are the questions as family representatives that we come to the table with all the time. There's a behavior add-on, but there's no requirement that you have any behavior training to get the behavior add-on. You know, there are a lot of things. Now, I'll stop. So our next speaker is from the Department of Medicaid, but he's going to be discussing what is becoming the call of the season. I'm retired now, and I'm on Medicare. My son with Down syndrome now is getting Medicare and Medicaid. I don't understand it. So Stephen Alexander from the Department of Medicaid is going to be here to explain My Care Ohio, which is for those people that we used to call duly eligible. Those people that are on Medicaid and Medicare. It will affect all of us eventually, whether it's our child or whether it's us. And I explained to Stephen that many of you who are providers have your, IRS doesn't want to say it's exempt, but you're not having your income counted, therefore you're on Medicaid and you hit 65. So it's not just your child. In many cases, and people in this room, it's also you that will also be on My Care Ohio. So Stephen Alexander, thank you.
Thank you so much, and thank you for having me. My name is Stephen Alexander, and I do realize it says Ohio Department of Medicaid up there. I do want to point out that I'm here to talk about the My Care Ohio waiver. I don't work directly on the EVV program, so as I was listening to all the questions, I thought I better just rip that Band-Aid off right at the beginning. So yeah, please bring those questions at 2:30 for Jesse Wyatt. That's going to be for him to explain. It does, the EVV program does apply in the My Care waiver as well, so sometimes I'll get pulled into meetings about it, but what I do want to talk to you about today is the My Care Ohio waiver and the My Care Ohio program. What I want to talk about is the My Care Ohio program. There are 7 waivers, and I've heard many of them mentioned today already, just in the question and answer period. I've heard SELF, I've heard IO, I've heard level 1 waiver mentioned as well. Those, of course, are the ones that dodd administers. There are 2 that the Department of Aging administers, passport and assisted living waiver, and then there are 2 that Medicaid administers directly. They're all considered Medicaid waivers because the federal match flows through Medicaid, but those 2, the Ohio Home Care waiver and the My Care waiver, are the final 2. So you might wonder, why are there 7 of these things? How are they all different? They have their own unique mission and sometimes target population. What is different about My Care is what we'll discuss. Go back. So I want to share a little bit today about the current My Care Ohio program. There are some changes that are coming to the My Care Ohio program, and we'll talk about who qualifies for it, what it covers, how the waiver is different, and I'll try to be quick too, since I also realize that I'm the only thing standing between you and your lunch. But yeah, there's also a question that's about the provider enrollment. That's not something that I'm going to be well versed to be able to help you through today. And we're also in the process of, since My Care is a managed care program, we're in the process of selecting the plans that will be our My Care plans in the future. So we can't get into any details about that selection process since it's a competitive, ongoing procurement. But certainly we can talk about anything about the current MyCare program. And it's only available in 29 counties today. So you might be from a county that's not a MyCare county, you've never heard of it. Maybe you're from a county that is a MyCare county, and you're very well familiar with it. I'm pretty darn sure I heard Maryland, Curtis.
Yes.
So yeah, I know you know all about it. But yeah, we'll talk a little bit more. At a high level, what MyCare is designed to do, what's attempting to do, and why it's a little bit different than the other waivers, is it's trying to bring in the Medicare program too. It's focused on what Gary mentioned, dual eligible Ohioans. People who are enrolled both in Medicaid and Medicare. So both of these programs were created in the 60s, and you think Medicare, you think people who are determined disabled by Social Security or they're 65 or older. You think Medicaid, you tend to think lower income. But there are many people, of course, who are in both of those categories and in both of those programs. But since they were created under different acts of Congress decades ago, they've each kind of gone in their own directions. They've diverged. And so Medicare is going to have its own policies about what providers they recognize, what services they cover, who qualifies, and what you have to do in order to be a provider. And Medicaid's going to do the same thing over the years too, especially since Medicaid is different in each state, since it's a state-administered program. And so these things don't always line up. So if you're in both programs, you might think, great, I've got two forms of insurance. Two should be better than one, but oftentimes it isn't, because you're trying to then figure out which one am I supposed to use for a particular service. And oftentimes, because the programs and the rules and the policies are different, you end up with both programs kind of pointing the finger at the other one. Go send that claim to Medicare. Medicare saying, no, go send it to Medicaid. And so Congress several years ago implemented a demonstration that states could voluntarily choose to do, where you would select managed care plans, and they would be tasked with managing both benefits. So you see there having that one organization. That's the goal of MyCare, because Ohio is one of the first states to do this, was to have a single managed care plan or health insurance corporation, and then you know where you're supposed to go, whether it's Medicare or Medicaid. And to the member, to the provider, it doesn't really matter at the end of the day, because the same plan is going to do both. And that should hopefully cut down on some of the duplicative confusion of the program, having different places to go to, whether it's a Medicare or Medicaid claim. And if there is kind of this fuzzy gray area about which program is supposed to cover a benefit, some common ones are behavioral health, or durable medical equipment, or long-term care, like nursing facility services. If you get into one of those areas where it gets confusing, hopefully, since that same organization is managing both benefits, they can just determine if it's medically necessary, pay or deny the claim, and then the stuff about which program is paying for it can hopefully be figured out on the back end. It doesn't result in nearly as many delays and barriers to accessing care that result in providers and members spending hours on the phone calling not one but two large bureaucratic health insurance programs. So having a single point of contact also then gets you hopefully some streamlined communication materials instead of getting a big stack of information from Medicare and Medicaid, and they both might say the same kinds of services. A good example is wheelchairs. Medicare will cover them that are designed to kind of get you around within your home, but Medicaid is the program that will cover ones with certain adaptations that can help get you around outside, navigate the sidewalk, etc. And oftentimes, this is a very common source of concern where people are having trouble, especially DME providers, trying to figure out where they're supposed to bill the claim. And oftentimes they have to go get a denial from Medicare before they can even try to bill Medicaid, even though the DME provider's done this enough times to know that it's, at the end of the day, going to be a Medicaid provider. So they ask, why can't I just bill them? And so it's MyCare is designed to try to make it a little easier to figure out where you're supposed to go, because that same plan, again, is going to be doing both benefits. And when you get information, you'll have all of the information on what's covered by your single plan instead of having to puzzle pieces together from two different sets of information. Maybe your Medicare plan offers you dental benefits, but Medicaid covers dental benefits too. So which one am I supposed to use first? If the same plan is kind of putting all the materials together, you have it all in one place, and you don't need to try to figure out which card am I supposed to use. And so that's another goal of the MyCare program. And so there's care coordination is a big feature of it as well, which doesn't exist in most Medicaid or Medicare fee-for-service. Now, obviously, in the DD space and the aging space, those are some exceptions because through the county boards or the area agencies on aging, many people do get care coordination. But outside of that, if you're in Medicaid fee-for-service, what's usually happening is the state is just waiting for claims to roll in. They pay or deny them. Nobody is actually trying to get you access to the services that you need, checking to see if you've gone to your annual well check, or making sure you have the drugs and the medical supplies that you need. When you have managed care, you do have somebody who's at least supposed to be doing that. And they will call and actually schedule appointments for you. They can, arrange transportation. Whereas in fee-for-service, the program becomes a little harder to navigate. Again, unless you have your county boards you can call or the area agency that's on aging if you're in one of those programs. But otherwise, it's more complicated to navigate it yourself, and that becomes even more complicated if you're dual eligible and you have to do that for 2 programs. So care coordination is another piece of MyCare where since it's through a managed care delivery system instead of fee-for-service where the state or the Medicare agency is doing it directly, you have that additional point of contact, that person you can call to help. A few benefits of being in MyCare as opposed to fee-for-service. One is you're less likely to get a surprise bill. We hear a lot of complaints where somebody goes to a provider who's in network with their Medicare Advantage plan. And that Medicare Advantage provider, you did what you're supposed to do, you went to a provider who's in network, but that provider, let's say, isn't a Medicaid provider. So they don't know, they're not supposed to balance bill you. They do that in Medicare. But you're not supposed to do that for someone who's on Medicaid. But since they're not a Medicaid provider, they don't know that. So you have that, oftentimes the bill goes out to the Medicaid member, and sometimes they'll even pay it, and they may not ever figure out they weren't supposed to and try to get that money back. When you have MyCare and you have a single organization who's got both benefits in their responsibility, that's less likely to happen because your providers who are in network are in network for both Medicare and Medicaid benefits, so they know not to bill the member. It doesn't happen. I can't promise it never happens, but it's much less likely to happen in MyCare because of that harmonization of the provider networks. There's also, we talk about care coordination. Enrollment broker, that's something that we offer where we have, if you're in managed care, there's a place you can call. It's a hotline number that I want to stress is distinct from when you call a county or you call your JFS for anything eligibility related. We hear all the time that those wait times are very long. For this hotline, when you would call to help you pick one of the managed care plans or one of the MyCare plans, the wait time is less than 30 seconds. And they have somebody who you can talk to, a live person, because we know a lot of people in MyCare, a lot of folks do not like to try to navigate online search tools or find which provider is my doctor in network of this plan or that plan. So the folks you talk to at the hotline can help you with that and help you pick the plan that has your doctor in network, has your providers, and they also have right there at their fingertips the value-added benefits that the MyCare plans offer, so you can find the best one of the MyCare plan options that you have. Move on. A few of the goals, because I know we're a little shorter on time. Some of the goals of MyCare are trying to make it easier to navigate because you have that same organization managing both. If you spend less time trying to figure all of that stuff out, you should have quicker access to the services that you need and hopefully get you more access to the preventative care. You're less likely to be hospitalized. We do find in MyCare, as opposed to non-MyCare counties, the inpatient hospitalization rates tend to be lower, and the Medicaid-funded portion of nursing facility services tends to be lower too. So, and then, making it easier to navigate. Talked already about a couple of these goals: streamlining care, making it person-centered, focusing on services like preventative service, well checks, making it easier to navigate. But then hopefully, because there are fewer but still meaningful options for members who are dual eligibles, you have fewer potential combinations of Medicare and Medicaid plans. We learned in the Cleveland area, for example, there are over 100 different options you could choose for your Medicare. And so if you have that in combination with however many different Medicaid options you could have, it gets to be very confusing when you submit a claim as a provider, what's going to happen. And so with hopefully with the MyCare plans streamlining these benefits and there being still options for folks, but not an overwhelming number, not 100 options, providers can start to rely a little bit more on what's going to happen when they submit a prior authorization or a claim. What MyCare covers, quite simply, it covers all of the same services that Medicare and Medicaid cover just together. So if you have Medicare Part A, B, or D, MyCare covers that. If you have Medicaid services today, it covers that too. And if you are on a nursing facility level of care waiver, the MyCare waiver covers those same services too. So personal care aid services, home delivered meals, we'll talk a little bit more about that in a minute. And then just like regular managed care or Medicare Advantage, the MyCare plans do offer value-added services in addition to their required benefits as well. So they can go beyond that. A lot of times it's transportation or rides. And so MyCare plans will frequently do that too. So eligibility. Who qualifies for MyCare? Really, it's just anybody who's fully eligible for Medicaid. And they're also fully eligible for Medicare. So you have Part A, B, and D, and you are on Medicaid, you probably qualify for MyCare. You have both of those things together. If you're 18 or older and you reside in one of the 29 counties where MyCare exists today. So there are a few exceptions to that. And for this group, I kind of want to point out that if you are in an ICF, if you reside in an intermediate care facility, or if you are on a dodd waiver, then MyCare eligibility doesn't extend into that realm. So you would stay on your dodd waiver on self-IO, you wouldn't get moved. And then also, if you're in an intermediate care facility, you also don't qualify for MyCare. I want to show the map real quick of where MyCare operates today. Like I said, it's in those 29 counties, and it shows you which plans are in each of those counties. So that's where it is. And real quick about the waiver services, you can kind of think of MyCare as covering, it's like Passport and Assisted Living and the home care waiver, where it covers all of those services, but it is through a managed care delivery system. So the MyCare plans are tasked with covering those benefits. So if you're on a nursing facility level of care waiver, a non-DD waiver like Passport, Ohio home care waiver, MyCare covers those if you're in the MyCare program too. And so you have to kind of meet that nursing facility level of care and then receive reasonably frequent waiver services. I think it's once a year really is all you need to do. And then MyCare will cover those waiver services. This is a list of the waiver services that are covered in MyCare. I'm sure this group is very familiar with waiver services and what tends to be covered by them, but just so you know, this is the list. It's pretty much a duplicate of what you will see covered in either Passport or a home care waiver, plus the assisted living service as well. So a little bit about what's going to be changing. And I'm watching my time, so I'm going to go quick just to leave some time for questions. There are a few changes coming to the MyCare program. I mentioned it was a demonstration that Congress permitted several years ago. Ohio opted into creating this demonstration program. That's why it's only in 29 counties. Well, the demonstration at the federal level, federal authority is ending at the end of calendar year 2025. So the current MyCare program can't exist into calendar year 2026. So you can use something that the federal government calls DSNPs to create new MyCare programs, MyCare plans. A DSNP is basically just a Medicare Advantage plan, but they can only enroll dual eligible members, so people who also qualify for Medicaid. And there are different kinds. But the kind that our MyCare plans today most closely resemble are the ones that are called fully integrated, meaning they cover all the services like I just described, Medicare and Medicaid together. So in the future, our MyCare plans that we're in the process of selecting will be this kind of Medicare Advantage plan that also covers Medicaid. And so we have to make those transitions. There are always a couple of little changes and things that the feds require that we have to alter and jump through the hoops in order to be able to move our current plans to the kind of plan that the federal government will recognize. So we have to do a lot of that hoop jumping too. And then on top of that, the state government, state legislature, when they passed the most recent budget bill, told us to take the MyCare program statewide. So it's not just going to be in 29 counties in the future, it will be statewide. They didn't give us a firm deadline by which to do that, so we wanted to try to be thoughtful and not go live with the flip of a switch, because there are plenty of area agencies on aging. There can be many independent providers who are in non-MyCare counties who have never contracted with a managed care plan. So we didn't want there to be a culture shock. So what we are doing is on January 1st of 2026, the new MyCare program will go live, but just in the 29 counties to start, where it currently operates. So folks who are providers, folks who are area agency on aging, waiver service coordinators, they have some time to adjust, and they're also a little bit familiar with dealing with managed care plans before we try to go into Southeast Ohio, or more rural areas, Northwest Ohio, where they don't have that experience and likely don't contract with a managed care plan. So one other key thing to note is in MyCare Ohio, it's currently the case that the area agencies on aging have to be the waiver service coordinators. So they don't have to do the full care management, but they do have to be the coordinators for waiver services for folks on the MyCare waiver who are 60 and older. So remember, just if you're a dual eligible doesn't mean you're on a waiver. You might be in a non-waiver population or not getting LTSS services. But if you are in that population and you're over 60 on MyCare, then the area agencies on aging today have to do the waiver service coordination. And so the legislature instructed us to keep that system going forward. And that means area agencies on aging in non-MyCare counties might suddenly have to start, well, they will have to start doing the waiver service coordination for the MyCare program too. So it's another reason we didn't want to expand too fast if they weren't ready. So when we go live in 2026, it'll just be the 29 counties, and we'll expand from there throughout 2026. We don't have like a specific timeline of which county will go live in which month, but just wanted to let you know what we know today, which is that's what we are planning on doing. So more specifics will come out in the future, but that's what we know today. And then the waiver services are going to be the same, where it's covered in these other waivers that I just mentioned. MyCare Ohio waiver will cover that too. And then one other piece to note is people who are dual eligible today, they have the option of choosing a different Medicare plan if they want to. So our MyCare plans cover the Medicare services, but let's say we hear frequently from people who say, I want to be in Medicare fee-for-service because I want to know that I can go to any Medicare provider. I want that wide network. Some people travel out of state and they don't want to deal with the harass of like when they go to a specific hospital in Indiana or Pennsylvania or wherever they need to go. They don't need to worry about, is my plan still going to pay them? If you have Medicare fee-for-service, you can go to any Medicare provider. And so some folks prefer to do Medicare fee-for-service for that reason, or choose a different Medicare Advantage plan. That's still something that's going to be permitted. So people will still be able to choose a different Medicare Advantage plan. Just know that you'll still have that unintegrated option where you have two different organizations, each managing a different part of your healthcare benefit. And that might cause some friction when you're trying to get claims paid or navigate services. A few areas of focus. I think this is close to the last slide. The MyCare program, we've heard from consumers in 2022. We met with ARC of Ohio. We met with Breaking Silences and Olmsted Task Force and several other groups to try to identify areas of improvement. And some of the common themes we heard were self-direction needed improved. And if you've been working on the self-direction efforts that Medicaid is working on in the home care waiver, those benefits that streamline the improvements that are coming to self-direction for home care waiver will also impact the MyCare program. I want to clarify what we're working on in self-direction. I don't believe impacts how self-direction works in the dodd waivers, but for those who are in the home care waiver, or if you're in MyCare today, you should have additional options for self-direction going forward. And transportation, we have several areas of improvement targeted for transportation that we can talk about if that's something we want to dive in deeper with our remaining time. And behavioral health, bringing in some specialists, kind of like with the aging population. We bring in the area agencies on aging to do waiver service coordination. We want to bring in behavioral health care coordination entities as well to have the experts on behavioral health access. That's a big need in our MyCare population as well. And it's never been the primary focus because the focus has always been on long-term care, waiver services. We want to have more of a behavioral health focus too, to make sure that members have help accessing and navigating the behavioral health system and get access to those services too. And then this is the last slide. There's an email address there where we are still welcoming questions or suggestions. If there's something that you're worried about, like, oh, I hope this doesn't happen, you can let us know there at MyCare conversion questions at medicaid.ohio.gov. If there's something that is working from the MyCare program, that's like, please don't change that. If you broke that, we would want to know that would be detrimental. Please let us know that too. There's a place where you can send in the mail as well. But yeah, that's a little bit about the MyCare program, some of the changes that are coming at a high level. I tried to go quickly so that we still have a few minutes for questions. So it looks like it's 9 minutes until we get to noon. So I'd be happy to take any questions with the remaining time that we have.
There's one here.
No? Oh, sorry. We gotta go get something.
Hello, Stephen. Nice to see you again this week.
Nice to see you too.
I want to know if someone is on a dodd waiver, current, but they turn 60, and there's more benefits available to them on MyCare. Can they do away with dodd and go to the MyCare waiver?
That is a really good question. And today, no, I don't think you can, since there are different levels of care, right? The DD level of care and the NIF level of care, they're different. So I don't believe you can make the switch from one to the other. When you get into waiver eligibility, especially if it's down to the clinical level, I get out of my depth pretty quick, so I don't want to misspeak. But today, you're right, you can't. If you're in a DD waiver and you qualify for that, I think it would be pretty difficult. I can't say it never happens, but it would be more of a clinical question at that time of what level of care do you meet in the clinical assessment. But if you meet like the nursing facility level of care instead of the DD, I think it's the ICF level of care that you need to meet in order to qualify for one of the DOD waivers, then that might be an option. But if you're on one of those DOD waivers, then that's kind of a mutually exclusive category from MyCare waiver because they're separate waivers. So yeah, I don't believe you can.
I'll ask Gary.
If it's something that, again, we want to see that change in the future, if you want to have more access for folks to be able to select MyCare plans, that's something that we'd be open to and want to hear more about. So please let us know, because I don't believe you even have the ability to choose a MyCare plan for your state plan services today.
Where we have seen it transitioning from like a level 1 to a home care, it's usually been someone who's aging, and they may kind of make GD level of care, but their health care because they're now 68. So
So someone can logically.
some, and we've actually seen some go from home care to DD. That's a more difficult transition.
Yeah, that's why
Your answer was correct, but
right,
if
that's why I
done,
wanted to make sure, that, especially since it's so dependent on clinical assessments, you can't really just give it. You can't say never or always, but it makes sense that that could be a common path where that sort of thing would happen.
Yeah, and the home care waiver, and I'm assuming this doesn't have the same waiting list rules that we do. So, if I've got the home care waiver, but I really want an IO, well, your needs are being met, therefore you don't qualify. We have all of these caveats.
Well, I've had Ohio Shared Living people say, but, we're not at this level of 24/7 care, but when they turn 60, I would get more benefits from my care. Can we switch that? I have no clue.
You can't switch, but there's always ways to go through, over, or around. Is that?
I'll just repeat that, just on the microphone so folks hear. You can't switch, but there might be ways to go over or around.
Yeah.
So I don't know if that's helpful, but I do know that when it comes to like navigating the different waiver eligibility, like I will help and work on the MyCare one, but it's pretty much a copy and paste of the passport, the home care waiver ones. So the difference between home care and passport, they're both nursing facility level care waivers, but there's a different age cutoff. Where if you're 60, if you're under 60, it's a home care waiver. If you're 60 or older, it's passport. So for MyCare, that doesn't matter. whether you're over or under 60, it's still going to cover those same kind of benefits from either of those waivers. But there is still more of a distinction between the NIF waivers, the nursing facility waivers, and then the dodd ones. So trying to go between those and cross that gap, that's where how you do it, I don't have the playbook or quite know how to do that. But I know
Sorry, I always jump in. But, so for those kids that are complex care, that can't get services from the DD, this might be an option. Okay, I just need to sit down.
You guys know me well. I've had 4 cups of coffee. And I had orange juice and no one's put vodka in it, as I asked. So,
Take the mic from me.
Hello. Thank you for talking about my care. Where can we go to read more or literature?
Oh,
Or
yes.
what you spoke on?
Sure. So the easiest way to find it, I should have had a link here, but even then, you have to get a digital copy of the slides. If you just Google MyCare Ohio, almost assuredly, the top return is going to be the MyCare Ohio page on Medicaid's website, the ODM website. And I find that a little easier than even going to the Medicaid website first and then trying to find it. If you just Google MyCare Ohio, the top option on Google is going to be the MyCare Ohio page on our website. We have these slides are there. You'll have a couple of one-page fact sheets, even specific to how the dodd eligibility interacts with Medicaid. There was a direct link to there from there, so that's a good place to go. There are also announcements and updates as we go through the selection process posted there. And we're also doing meetings throughout the state. We're trying to meet with dual eligible members. And so there's even a schedule of when we're going to be in a different place throughout the state that you can register and attend there too if you want to.
These presentations will be on the ARC of Ohio website by Sunday under resources, so all 3 of them.
Yeah, just on these slides will be on the ARC of Ohio resources page by Sunday.
Hi, it's Megan.
Hi.
So my question, I'm going to piggyback off the rest of the people that are here. While we appreciate all of your representatives coming out and you sharing time as we've done with you, it would be really, really useful if you came here with literature so that we can have easy access to these programs. I know I'm approved for a lot of different programs, and I can't get a representative on the phone. I don't understand some of the nuances of them. So it impedes me from being able to have, or people who will want the services, or being able to have the services because I feel stuck. And so when you come here, it's kudos to you, but it would really, really help us if you came here with like a packet, just like you have the slides, just have them printed out for us to pick up in the lobby and go through it through our leisure. All the accessible programs that are available for us independents and agencies and everybody else, so that we know what we can possibly provide or not, and how we can make that happen. Instead of looking through websites, email, and that takes away from our services. You know, if you're an IT like me, time is, critical. And we don't have to navigate through the system to try to provide services for free. If that makes sense.
Oh, absolutely.
I'll make sure that the ARC has it printed out.
And this is my first time being here, but yeah, if I'm invited back next year, I'll definitely bring things in printed form. I'll remember. Oh, no, that's completely fine. I don't think I got to the slides until yesterday anyway, so you probably wouldn't have had time. But yeah, your frustration with the website, I share. That's why I said just Google it because it's quicker. I get on the Medicaid website all the time just trying to navigate, and I work there and trying to find things that is very challenging. So I share that criticism, actually.
Hey, this is Kim Kelly. Hi. I just have a question you may not be able to answer, but do you know how many people statistically have moved from MyCare to a dodd waiver because of their complex care or medically fragile?
No, I don't. How many people have moved from that? No, I haven't. I checked. That would be a good thing to kind of look into, but to be honest with you, I know once you do qualify for a dodd waiver, you no longer qualify for MyCare, but I don't know the frequency of those payments.
Yes, because we have people on the Ohio Home Care Waiver, and we have people on the My Care Waiver that are actually trying to get onto dodd waivers because they cannot be served under those two waivers. I just wondered if you had statistics for that.
And I'm curious, what's the gap? What is the issue that they can't find the need for the
Medications are one of them.
medications?
Yeah, medication administration, as well as they have, a lot of them have autism, or they have very complicated, rare conditions that cannot be served with a personal care aid, because the personal care aides on the Medicaid side are intrinsically different than the HBC staff on the dodd side.
Okay, that's good to know. Thank you.
Good morning. If you could stare into your crystal ball for a minute. My son, it'll be a few years before he makes the transition. He's on a DODD waiver, does not have important medical needs. But at some point, he's going to move to Medicare with Medicaid behind it. You stare into the crystal ball, and right now managed care is not involved. He's not involved with any managed care system. Sure. If you stare into your crystal ball, is he going to be dealing with, in that transition point, do you think he's going to be dealing with managed care? And I ask this from, my perspective is, I deal with all of his, with some help from the county board, obviously, but I deal with Social Security and all of those systems today, and they're really good at killing trees and confusing people. And I'm also dealing with my wife's aging parents and some things related to them, and the whole Medicare insurance kind of bureaucracy is hard. And I'm concerned long-term about how my son's how somebody's going to have to help my son, because he's obviously not going to navigate these systems by himself.
That's a great question. If I were to, obviously couldn't say with certainty if he's going to be dealing with a managed care plan, would really be interested to learn more about if you feel that would be helpful, or if folks feel that, if folks want that option and that ability, because as it stands today, I don't know. As it stands today, the waiver enrollment, the enrollment in the dodd waiver basically puts you in the Medicaid fee-for-service. And I think your Medicare options are still pretty open, so you would still be able to choose any Medicare Advantage plan for your son, whoever was helping him pick the Medicare Advantage plans as well. But you're still trying to figure out, trying to piece things together. I would be really curious to learn more if people on the dodd waivers and their families or support system would want to have the MyCare option for their state plan services. As it stands today, we're not planning any change that I know of where that would become an option, where they could sort of choose a MyCare plan for their state plan services. But to sort of answer to at least make one clarification, I guess I'd say, is whether you're on Medicaid through MyCare or not, the services are still the same. But I hear you, your question is really about how is it going to navigate them. And if there is something in the MyCare program that could be beneficial to folks, and that's an option that people would want, that would be really good to know. But I couldn't say for sure if that option will ever be made available, if you're going to be dealing with managed care plans, because things could change from one administration to the next, legislation could pass. But as just looking at what we have today, that change isn't imminent. There's no plans to make that change. So it would just be, if your son, like if that happened today, he would just be on Medicaid, and he would have all the Medicaid covered services, but he wouldn't be in the managed care.
So the casino thinks we're eating at 12:30. My stomach said noon, and so did the agenda, so. If you want to. Anyone want to say?
Talent show?
We got one more. We can even take a break.
Yeah. Bathroom break?
As a person with ED, I'm learning about Medicaid because my county board has decided to cut local funds from $10,000 to $750. Who's that gonna hurt? Me. So I won't have a job because I won't have a payee if I don't get on Medicaid by December of this year. That hurts me. And I think Medicaid needs to be talked to because you guys have a lot of red tape. And if I get on Medicaid, am I able to get onto my care? If I have to have, because I have to get a waiver in order to keep my services. And if I get on that waiver, and if I don't get on the waiver, what am I going to do? What are the options? Because I have insurance right now through my work. I'm lucky I can work full time. I'm lucky I'm out in the community. I'm lucky my disability does not hinder me from working. And as a working person, I want to work. I want to be out in the community. I'm a social person. But if Medicaid denies me, which they're going to, I know it because I got a free running services, am I able, if I get Medicaid, where I'm able to get onto my care waiver?
So if you're on a dodd waiver like level 1 self or the individual options waiver, then that's a different program for MyCare, and you would also be able to be on MyCare. You can still qualify for Medicaid. You can still have Medicaid covered services. You don't have to be on MyCare to get Medicaid services. But being with a MyCare plan would have those additional case management or care coordination services that you don't have through Medicaid fee-for-service. So that's the difference. But you could still get Medicaid and have services covered, but it sounds like you're worried that it would just be hard to navigate and figure out how do I get access them. So if that's something that you want to be on MyCare, that would be great to know, because I can't say that I personally have heard very many people asking for it. I think Marilyn was the first who broached the subject with me. But if that's something that folks want, that would be great to know.
Thank you. Thank you, Stephen. I don't know how to work the mic.
So let's take a break. They're setting up for lunch. Don't go too far, but if you want to win something, have at it. They're setting up for lunch. I think